Bismillahirrahmanirrahim. I'm going to have a talk on an important topic, systemic sclerosis today. So we begin our talk now. Assalamu alaikum students. Again I'm here to talk about an important topic which is of vital importance in medicine as well as dermatology, which is mostly a reflection of systemic diseases on skin. So today we are going to talk about systemic sclerosis, and this is Dr. TAHIR Kamal giving a talk on this subject. I'm working as an assistant professor in Department of Dermatology, Lahore General Hospital and Amiruddin Medical College, Lahore. The term scleroderma is derived from Greek word scleros, which means hard or indurated, and derma obviously means skin, and it is used to describe a disease characterized by progressive skin hardening and induration. Scleroderma is an aspect of systemic sclerosis, a systemic connective tissue disease that also involves subcutaneous tissue, muscles, and most importantly internal organs also. And diagnosis is based on clinical manifestations and tests and procedures, which we'll discuss in our talk. And treatment is principally towards managing the complications and symptomatic relief to the patient. So it is progressive thickening of basically dermis because of abnormal fibrogenic response, and it leads to ultimately involvement of organs, developing complications in skin as well as other organs. Systemic sclerosis is a disease which mostly affects younger women, and female to male ratio is 3:1. So mostly it is affecting in the age of second or third decade, and mostly affects women in the age of 20s or 30. The term systemic sclerosis, as I mentioned, is a disease to describe a systemic autoimmune disease of unknown origin, characterized by excessive deposition of collagen and other connective tissue macromolecules in skin and in multiple organs, and severe fibroproliferative alterations in the microvasculature, and numerous humoral and cellular immunological abnormalities. The endothelial cell dysfunction is the basic factor which is involved in the pathogenesis of systemic sclerosis, and this endothelial cell alteration and dysfunction allows chemokines and cytokine mediated attraction of various inflammatory cells and fibroblast precursors, which are called fibrocytes, from the bloodstream and bone marrow, and their transmigration into the surrounding tissue, resulting in the establishment of chronic inflammatory process with participation of macrophages and especially T and B lymphocytes, which further cause production and secretion of cytokines and growth factors from these cells. The exact etiology of systemic sclerosis are not clearly known, but it is clear also that it is not practically inherited, although a genetic predisposition plays a a vital role in the development of this disease. The environmental factors, which are called triggers, may contribute to the development of systemic sclerosis, and these environmental factors include silica exposure, solvent exposures like vinyl chloride, epoxy resins, carbon tetrachloride, radiation exposures. These all aggravate the disease and may contribute in the pathogenesis of systemic sclerosis. Including some of the viruses may alter endothelial dysfunction, which I already clearly mentioned is an initial event in the progression of this disease. Viruses like cytomegalovirus, human herpes virus 5, and parvovirus B19, these all have been proposed as a contributing factors in the pathogenesis of systemic sclerosis. Different factors including genetic, environmental, vascular, autoimmunological and microchimeric factors are involved in the pathogenesis. And one theory also states that antigens from the human leukocyte antigen HLA histocompatibility complex, including HLA-B8, HLA-DR5, HLA-DR3 and HLA-DR52, these are involved in systemic sclerosis, along with the possibility and suggestion that apoptosis and generation of free radicals may also be involved in the pathogenesis of systemic sclerosis. So students, please concentrate on this slide. This is whatever we have discussed in past few slides regarding the pathogenesis, because understanding of pathogenesis of systemic sclerosis is important. That would help us in choosing our treatment, management and understanding the complications of systemic sclerosis in much better way. So if we summarize or look into all factors which cause or lead to systemic sclerosis, these factors include, again I am repeating, environmental factors, immunological disturbances and vascular changes. So endogenous or exogenous antigen presented by antigen presenting cells, they alter the endothelial cells, and these endothelial alterations may lead to a cascade of stimulatory changes that involve many cells. And these cells include fibroblasts, T lymphocytes, macrophages as well as mast cells. In turn, the activated cells secrete a variety of substances, include cytokines and enzymes as well as their inhibitors. Then these substances lead to changes in extracellular matrix, including fibronectin, proteoglycans and collagen types 1, 3, 5 and 7. So increased collagen deposition in tissues is a characteristic feature of systemic sclerosis, and increased collagen production or disturbances in its degradation can cause excessive collagen deposition in various tissues and microvasculature, which leads to ischemia and produce signs and symptoms in systemic sclerosis. Fibrosis can be caused by profibrotic cytokines, including transforming growth factor beta, interleukin 4, platelet derived growth factors and connective tissue growth factors. So the vasculopathy may be linked to a transforming growth factor beta, while the constriction or diminution of lesional cutaneous blood vessels can be attributed to endothelial cell antibodies. And ultimately there is activation of immune system, which is of paramount importance, and activated T cells infiltrate the skin and produce pro-fibrotic cytokines interleukin 4. And B cells may also contribute to fibrosis, as deficiency of CD19, a B cell transduction molecule, results in decreased fibrosis. So genetically, patients with histocompatibility complex, as I earlier mentioned, HLA-B8, DR5, HLA, DR52, they also play their role in the pathogenesis of systemic sclerosis. Now we discuss clinical types of systemic sclerosis. Basically, we divide into limited and diffuse cutaneous systemic sclerosis, and there is also a third type which is rare, which you can keep in mind. Beside limited and diffuse cutaneous, there is a third type clinically which is called scleroderma sine scleroderma, in which there is involvement of the internal organs with Raynaud's phenomena, pulmonary involvement, and other organs are severely affected, but there are no signs and symptoms or involvement of skin as such. So this is the third type. And systemic sclerosis affects the skin as well as what is underneath, such as blood vessels, muscle, joints, gastrointestinal tract, kidneys, lungs, and heart. The skin thickening that accompanies systemic sclerosis can cause tightening, so there is a loss of flexibility of skin, and it's difficult to have proper movements, especially of the fingers, and there is degeneration of bones as well. So these are there is tapering of fingers, which you can observe clinically with hidebound skin or tight skin over it, which you cannot pinch properly if you clinically examine the patient. Facial involvement is common, and it may be mild or it can reduce facial lines. The face is more of a mask-like, and clinically you can easily observe there is decreasing of mouth opening or difficulty in mouth opening. Scleroderma can also cause chronic joint inflammation, and most scleroderma patients have Raynaud's phenomena positive. So moving on to the two types, limited scleroderma, it is relatively having a benign course, at systemic organ involvement is less likely in limited cutaneous scleroderma. And there is a subtype of limited scleroderma which is called CREST syndrome. The other is a diffuse cutaneous, which is more rapidly progressive disease as compared to limited cutaneous scleroderma, and the clinical signs or the involvement of multiple organs is quite rapid in diffuse cutaneous scleroderma, especially the lungs and kidneys. So they are quite early involved in diffuse cutaneous scleroderma. This is a patient of diffuse type of systemic sclerosis. You can see the changes on hands, face, pigmentation on neck, having a tight bound skin with pigmentary changes, and as you can clearly see on the dorsum of the hands, there is pigmentation along with the white spots. So this is the poikilodermatous skin, which I mentioned is a combination of hypopigmentation with atrophy and telangiectasias as well. Limited scleroderma is the most common type of scleroderma. The skin is having hardening and tightening, which is usually limited to just fingers, sometimes hands, forearms, and it can involve face, but it leaves other areas with the skin tightening, such as trunk or the lower limbs. They are usually spared. Internal organ damage is less likely in limited scleroderma type. In general, patients with limited cutaneous scleroderma have more or less normal life expectancy, except few have problem with GI tract or dyspepsia. Raynaud's phenomena is common, and there is musculoskeletal pain. And here we need to mention a subtype of limited scleroderma, which is called CREST syndrome, and this is an acronym for its important clinical feature. C stands for calcinosis, which is an important feature. You see over the bony prominences and other parts of the body, especially limbs, where there is movement. You can see, you can clinically also feel, and you can clinically observe the calcium deposits in a form of chalky white color deposits, which may become ulcerated or sometimes painful. So C stands for calcinosis, R for Raynaud's phenomena, E for presence of esophageal dysmotility, S for scleroducty. As I mentioned, there is resorption of bone because of poor blood supply and ischemia, causing resorption of the bone, and along with that, as we clearly explained in the earlier part of the lecture, that there is deposition of collagen, so there is tight hidebound skin over the digits, so this is called scleroducty. And last but not least, T stands for telangiectasia, especially in CREST syndrome. This is an important clinical sign where we find mat-like telangiectasias on face, especially the cheek area. So these are features of limited cutaneous scleroderma. And if you go for the lab test, anti-centromere antibodies is present in 70 to 80% of cases. So less likely to have pulmonary hypertension and renal involvement is rare in limited cutaneous scleroderma. Students, you can see radiographs of hands in a patient of especially CREST syndrome, and you can easily identify opaque calcification involvement and calcinosis on the digits. So it's a very clear-cut radiographic evidence of calcinosis in patients of CREST syndrome. Here you can see few of the features. As you can see on the left side, there are calcinosis and calcific deposits. Then comes the finger, which you can see pale digit. This is actually clinically sign of Raynaud's phenomena. Then there is sclerodactyly with tapering of fingers, and radiographic calcinosis on X-ray can be seen as form of deposits. So this is CREST syndrome, and a few of the clinical pictures and radiographs of this syndrome shown in this slide. Here you can see a patient of diffuse cutaneous scleroderma or systemic sclerosis, and as I clearly mentioned, there is resorption of finger with hidebound skin, so you can see there is no cutaneous markings or prominent lining. It's a shiny skin, tightening of skin, even involving the forearm, and there is tapering of finger. And later on you experience clinically, if you examine patient, there are digital pitted scars on the pulp of the fingers. That is also an important sign in the diagnosis of diffuse cutaneous systemic sclerosis. Again, this is just a brief revision of limited scleroderma with explanation of CREST syndrome. which you should keep in mind as a subtype of limited cutaneous scleroderma. Now moving on to the other type, diffuse scleroderma is a subtype of scleroderma where excess collagen production causes skin thickening over a large area of the body, usually the fingers, hands, arms, interior trunk especially, along with face, even the legs, feet area and face, they are all involved. So involvement of area is almost far more than the limited cutaneous type, and especially there is significant associated organ damage. As we said, it is a multi-organ disease, so it includes gastrointestinal tract involvement, kidneys, lungs, as well as CVS, heart. The tightening of the skin is often associated with dryness and itching, and musculoskeletal pain is far more than limited cutaneous scleroderma. It is to be remembered that if you go for lab test, and it is quite specific test for scleroderma, so antibodies to SCL70 antibodies are positive, which are highly specific for systemic or diffuse scleroderma. The specificity is quite high, as well as sensitivity. So these are antibodies, actually antibodies to topoisomerase 1, and the other antibodies which are even more specific than SCL70 antibodies, present in only around 15 to 25% of the cases. It is anti-RNA polymerase 3 antibodies. So usually we go for clinically for anti-SCL70 antibody test in diffuse scleroderma. Some of the more pictures of diffuse systemic sclerosis. You can see Raynaud's phenomena with ischemia in the little and ring finger, then hyperpigmentary changes with tight bound skin, contracture of the hand, as well as if you can see changes in the lung, there is basal pulmonary fibrosis also. Now students, please carefully look at this slide. It gives you a brief idea and difference between a limited type of systemic sclerosis and diffuse type. So if we just highlight briefly a few of the important differences. As you can see, in the limited type there is distal skin involvement, distal to the elbows and knees, and no truncal involvement, but may involve face and neck. So truncal involvement is an important clinical feature of diffuse cutaneous type, which is not present in limited cutaneous type. And diffuse is proximal to the elbows and proximal to the knees and truncal involvement, and also distal skin involvement along with involvement of face and neck. In limited cutaneous systemic sclerosis, Raynaud's phenomena occurs quite early, before other organ involvement or skin involvement is occurring. So there is a long interval between onset of Raynaud's phenomena and involvement of skin or cutaneous involvement. But in case of diffuse systemic sclerosis, there is a rapid progression, and there is a very short interval, even less than a year, between onset of Raynaud's phenomena and you can clinically see or patient experiences cutaneous symptoms earlier than 1 year. So there is rapid progression in diffuse cutaneous systemic sclerosis. In limited cutaneous, mostly we see positive anti-centromere antibodies. In case of diffuse systemic sclerosis, mostly SCL70 antibodies are present, though they are present in 30% of cases, but it's very specific. And otherwise, lung involvement and renal and heart involvement, organ involvement is not feature of limited cutaneous systemic sclerosis, but in case of diffuse systemic sclerosis, these organs and systems are involved quite commonly, especially lungs, and leading to high mortality in case of diffuse cutaneous systemic sclerosis. So dear students, if we take up the clinical feature and we divide it into different or various organ involvement, so broadly we can look into each of the system involved by systemic sclerosis and how it is involved. So we simply classify according to systems involved: cutaneous, then musculoskeletal, pulmonary system, renal involvement, gastrointestinal involvement, and cardiac involvement. So first, if we take up cutaneous involvement, there are early changes, there are late changes. Obviously, as the disease progresses, initially there is tightening of skin, as we initially mentioned in our early part of the lecture. So in early involvement, there is beginning of tightening of skin. It becomes more of shiny in nature, with loss of sweating and skin markings on the skin surface, and especially pigmentary changes begin to appear, and it is in the form of hyperpigmentation, and then in the little chronic form of the disease you find white patches intermingled with hyperpigmented patches. So please remember the term, it becomes more of poikilodermatous skin. It's a combination of atrophy, telangiectasia, and loss of pigmentation at certain point, and there is hyperpigmentation on some other sites. So it's a combination skin with tightening of skin, especially there is also ulceration over the bony prominences, over joints, calcinosis, and calcific deposits. And you also see capillary changes, especially around the nail, proximal nail fold. So if you examine with the ophthalmoscope, you can easily see the changes in capillaries in patients of systemic sclerosis. There is especially important dropout sign, and which is actually you don't see the normal picture or normal capillaries in patients of systemic sclerosis because of digital ischemia, and later on causing digital ulcers, especially on the pulp of the finger. So these are the prominent changes in cases of systemic sclerosis. There is loss of hair also on the skin as the disease progresses, and there is tightening of skin. Patient is unable to open his or her mouth. So all changes come with the progression of disease, and if it is involving front of the chest, it's difficult for patient to breathe. So ultimately these are the complications which develop if the disease is in progression, or if it becomes chronic in nature. just a revision of what I have just mentioned in cutaneous involvement in systemic sclerosis. Skin thickening in the trunk, digital ulcers and digital ischemia leading to pits and digital pitted scars, and complications due to prolonged Raynaud's phenomena. Especially Raynaud's phenomena is prominent, or it is severe in cases of diffuse cutaneous systemic sclerosis, and there is thinning of the lips and beak-like nose, which can easily appreciable in cases of chronic or severe cases of systemic sclerosis. In this slide you can see the cutaneous manifestation. In the first picture there is typical facies of systemic sclerosis. Then there is involvement of digits, is unable to properly contract fingers because of tightening of skin and involvement of joints. The other slide showing because of digital ischemia and Raynaud's, there is digital ulcer and even development of gangrene, and lastly involvement of bone with resorption of finger and distal bones, especially metacarpal bones, and involving distal part of the digits first, and then moving proximally. Then comes the involvement of musculoskeletal system. We have mentioned earlier also, there is the involvement of joints, there is arthritis, resorption of bone, and because of tightening of skin and involvement of joint is flexion contractures, polyarthritis, there is extreme myositis, muscle weakness. Especially remember that systemic sclerosis can also be a part of or involved with associated or other connective tissue disease can be present in same patient, where we label patient as case of mixed connective tissue disease. So in that case, myositis is a prominent feature, especially if systemic sclerosis in a patient is occurring along with features of dermatomyositis or systemic lupus erythematosus. So it may occur as a part of mixed connective tissue disease, which is called overlap syndrome also. Then there is carpal tunnel syndrome because of fibrosis and extreme involvement of tendon, because tendons are passing through the carpal tunnel. That's why it is called carpal tunnel syndrome. There is involvement of hands with difficulty in movement, especially involving the median nerve distribution, and there is loss of muscle and there is atrophy. So you, on the examination of the hands, you will find loss of thenar, hypothenar evidences. So that is a sign of muscle atrophy. Then there is very important system which is involved in cases of systemic sclerosis. It is called involvement of lungs or pulmonary involvement. 2/3 of the patients are affected, especially in cases of diffuse systemic sclerosis, or when systemic sclerosis is a part of mixed connective tissue disease. It is a leading cause of mortality and morbidity in later stage of systemic sclerosis. And basically, you must remember, it causes interstitial fibrosis and intimal thickening of pulmonary arterioles. Ultimately, in pulmonary function test, you see reduced FEV1 and difficulty in breathing, of course. And this is ultimately leading to pulmonary hypertension, or patient complains of dry cough, breathlessness, So these are the important feature of pulmonary involvement in systemic sclerosis. Now there is involvement of renal system in systemic sclerosis, and diffuse systemic sclerosis, it is associated with rapid progression of skin involvement as well as renal involvement. As far as renal system involvement is concerned, there is intimal hyperplasia of the interlobular artery. There is fibrinoid necrosis of afferent arterioles, ultimately causing glomerulosclerosis, and there is extreme proteinuria. If you go for 24-hour urinary protein test, it is rapidly increasing, even more than 5 gram per day in a patient of systemic sclerosis. And there is renal hypertension, which is a very crisis situation, and there is a term called malignant hypertension, which is associated with advanced disease or in a patient of advanced systemic sclerosis. So renal involvement is an important part of the organ involvement in cases of systemic sclerosis. And there is proteinuria, as I mentioned, and azotemia, microangiopathic hemolytic anemia, and ultimately leading to renal failure. Then there is involvement of gastrointestinal system, and especially if we go one by one in a different, dividing intestinal involvement into esophagus involvement, stomach involvement, small intestine, and large intestine. So we can if we talk about involvement of the esophagus, there is hypomotility, difficulty in swallowing, especially in history. Patient gave very clear history of difficulty in swallowing, especially solid foods. Then as the disease progresses, semi-solid food also, and there is retrosternal pain, there is reflux and GERD-like symptoms, heartburn, reflex esophagitis, and ultimately leading to stricture of the lower part of esophagus. Then comes the stomach. There is delayed emptying, stomach ulcers, and sometimes as a counter reaction or formation of new vascular formation, and there is increased blood vessel formation in the stomach lining, which is called watermelon stomach. Then comes the small intestinal involvement with pseudo obstruction, paralytic ileus, malabsorption, leading to weight loss and cachexia. And last but not least, large intestinal involvement with similar fibrotic process going on in the submucosal layer, causing chronic constipation and dilatation of large intestine with later on with obstruction and fecal infection, diverticular formation. So these are all leading to nutritional deficiency, especially vitamin B12, folate deficiency, vitamin B12, vitamin D, low albumin. These are all ultimately due to involvement of gastrointestinal system in cases of systemic sclerosis. Then comes the involvement of heart or cardiac involvement, approximately involved in 10% of the cases of systemic sclerosis. So simply I would say in cardiac involvement there is pericarditis, heart failure, and ultimately myocarditis. Inflammation leads to fibrosis, arrhythmias, and especially conduction abnormalities, atrial and ventricular fibrillations, and myocardial fibrosis, because fibrosis is occurring in nearly all parts of the body and various organs. So heart is also involved with that, and with pericarditis there can be a pericardial effusion with its proper symptoms and signs. So cardiac involvement should be properly dealt with and should be looked for, especially patient must have echocardiography after ECG, and we should find changes. So it must be properly looked for in cases of systemic. This is a slide showing presence of certain antibodies which we have already discussed and their correlation with the organ involvement. So you can have a detailed look at it. As you can appreciate, certain antibodies, they indicate presence of overlap syndrome. Besides systemic sclerosis, patient might also be suffering from dermatomyositis or systemic lupus erythematosus. So every antibody, positivity or presence of antibody in a patient gives us a clue of chances of organ involvement in the course of disease. This is a slide showing presence of certain antibodies which we have already discussed and their correlation with the organ involvement. So you can have a detailed look at it. As you can appreciate, certain antibodies, they indicate presence of overlap syndrome. Besides systemic sclerosis, patient might also be suffering from dermatomyositis or systemic lupus erythematosus. So every antibody, positivity or presence of antibody in a patient gives us a clue of chances of organ involvement in the course of disease. This is a slide showing presence of certain antibodies which we have already discussed and their correlation with the organ involvement. So you can have a detailed look at it. As you can appreciate, certain antibodies, they indicate presence of overlap syndrome. Besides systemic sclerosis, patient might also be suffering from dermatomyositis or systemic lupus erythematosus. So every antibody, positivity or presence of antibody in a patient gives us a clue of chances of organ involvement in the course of disease. This is a slide showing presence of certain antibodies which we have already discussed and their correlation with the organ involvement. So you can have a detailed look at it. As you can appreciate, certain antibodies, they indicate presence of overlap syndrome. Besides systemic sclerosis, patient might also be suffering from dermatomyositis or systemic lupus erythematosus. So every antibody, positivity or presence of antibody in a patient gives us a clue of chances of organ involvement in the course of disease. This is a slide showing presence of certain antibodies which we have already discussed and their correlation with the organ involvement. So you can have a detailed look at it. As you can appreciate, certain antibodies, they indicate presence of overlap syndrome. Besides systemic sclerosis, patient might also be suffering from dermatomyositis or systemic lupus erythematosus. So every antibody, positivity or presence of antibody in a patient gives us the clue of chances of organ involvement in the course of disease. This is a slide showing presence of certain antibodies which we have already discussed and their correlation with the organ involvement, so you can have a detailed look at it. As you can appreciate, certain antibodies, they indicate presence of overlap syndrome. Besides systemic sclerosis, patient might also be suffering from dermatomyositis or systemic lupus erythematosus. So every antibody, positivity or presence of antibody in a patient gives us the clue of chances of organ. Now, starting with the treatment of systemic sclerosis, I would like to begin with the important manifestation of connective tissue disease, which is also present in systemic sclerosis, and this is called Raynaud's phenomena, where there is an abnormal response to any cold stimulation, especially cold water, cold temperature. So your vessels, blood vessels, they don't respond normally because normally they undergo vasoconstriction, and when temperature normalizes, they dilate. But in connective tissue diseases, or especially in Raynaud's phenomena, this mechanism is disturbed. So if patient is suffering from severe Raynaud's phenomena along with the progression of systemic sclerosis, there are chances of extreme ischemic ulcers, even leading to gangrene, excruciating pain. So to deal with that, we can begin with calcium channel blockers like nifedipine, or in severe cases nitroglycerin patches, which is also vasodilator. Then remember, we can give iloprost, different brand names. So it is also vasodilator, especially indicated in cases of pulmonary hypertension with severe digital ischemia or Raynaud's phenomena. And last but not least, we can go for phosphodiesterase inhibitors like sildenafil in lower doses, and that also helps in patients, especially in cases of pulmonary hypertension associated with systemic sclerosis. In cases of gastrointestinal involvement, first of all, start with simple measures. Patient is advised to elevate head during sleep. Patient is advised to have small frequent meals, and in advanced disease where there is esophageal dysmotility and difficult to eat solid foods, patient is encouraged to have high energy liquid drinks or semi-solid food. If patient can have intake of semi-solid foods, avoid lying down within 3 to 4 hours of eating. Patient must quit smoking, and we can also obviously start H2 blocker, proton pump inhibitors, and pro-motility agents can be added like metoclopramide to avoid reflux esophagitis. So these are important measures in treatment of systemic sclerosis if there is gastrointestinal involvement. So when there is severe lung involvement, various options are kept in mind, but you can memorize these important treatment options. I must stress one point, that if you are giving some immune modulator or some immunosuppressant medicine, patient must be properly evaluated and look for any other complications like renal complication, the pulmonary status based on pulmonary function test and high resolution CT scan of the chest, because there are certain medications which can increase pulmonary fibrosis, so they should not be opted in the advanced disease. So if there is interstitial lung involvement, which is a major organ involved in case of systemic sclerosis, cyclophosphamide is a good choice to reduce the progression of lung involvement. Then there is azathioprine. Mycophenolate mofetil is quite safe and effective medicine when given to the patient with advanced interstitial lung fibrosis or interstitial lung disease due to systemic sclerosis. Then bosentan, which is endothelin receptor antagonist, helps also with the digital ischemia and cutaneous changes due to ischemic ulcers, and causes dilatation of blood vessels. Then iloprost or sildenafil, especially in cases of associated pulmonary hypertension. So these are the basic and few important medications used for advanced involvement in form of interstitial lung disease in cases of systemic sclerosis. Students, for typically for cutaneous involvement, and there are various options, but remember, low dose methotrexate like 7.5 milligram per week is an initial option for cutaneous involvement in cases of systemic sclerosis, along with hydroxychloroquine. And there are other medications which can be given as an adjuvant. This also helps in stopping the progression of fibrosis. Like colchicine can be given, causes reduction in inflammation and causes reduction in fibrosis also. Then again, mycophenolate mofetil can be a good choice if we are looking at cutaneous involvement in patient of systemic sclerosis. Then there are disease modifying drugs which are not currently being used so frequently, but it was used in past quite frequently, like D-penicillamine. So that can be also an option, but D-penicillamine has this side effect because it can cause pseudo scleroderma. So these are the few choices as far as cutaneous involvement is there. And as I mentioned, if digital ulcers or digital ischemia is there, causing digital pain and ulcerations, scarring. So again, I am repeating, vasodilators like calcium channel blocker, iloprost, or phosphodiesterase inhibitors like sildenafil, also helping with pulmonary hypertension. Bosentan, which is endothelin 1 receptor antagonist causing vasodilatation, and nitroglycerin patches. These are all helpful in cases where cutaneous involvement is due to ischemia and constriction of blood vessels. So these are the few main treatment options. This is a strategy, just briefly, you can again as an approach, and especially depending on the changes and your clinical findings, and the organs and systems involved in the patient, you can approach accordingly, and selection of medicine and treatment strategy. So drugs that prevent vascular damage are ACE inhibitors in a low dose, help in preventing renal complications and failure. Then as I mentioned, bosentan, which is endothelin receptor agonist, a vasodilator that can help with ischemic changes, ulcerations on fingers, digital ischemia, pain. So as a vasodilator, it is very helpful in chronic non-responding cases, especially to platelet lowering drugs. Then bosentan can be a choice. And the drugs that suppresses the inflammation as an immune suppressant or modulator, azathioprine, cyclophosphamide, methotrexate, chlorambucil, 5-fluorouracil, these are all important options. Drugs that suppresses fibrosis, these penicillamine have been a choice, but not usually used nowadays because of its some of its side effects and less effective clinically, but it suppresses fibrosis, especially tightening of skin and cutaneous fibrosis. So deep in penicillamine, then gamma interferons, relaxin, even colchicine, these all help as an adjuvant therapy in reducing the process of fibrosis. So thank you students for listening my talk on systemic sclerosis patiently. I've actually tried to cover briefly all the aspects, but it's a wide topic, and with time, experience, you learn so many aspects of it. So with this I conclude my talk, but you must remember systemic sclerosis or scleroderma, actually a term used for skin thickening, and there can be many important differentials of this disease before you label a patient of systemic sclerosis. There are other conditions which I won't go into detail, but you should keep in mind, like scleral mixed edema, cases of monoclonal gammopathy, multiple myelomas, amyloidosis, endocrinopathy, nephrogenic fibrosing dermopathy. So these are all conditions which have skin thickening, but they don't fulfill the criteria. You can properly again listen to the lecture and our talk. You can well appreciate in other conditions these criteria and these clinical features. They are not fulfilled, but they mimic systemic sclerosis. So thank you once again, and I conclude my talk with that, and I am grateful to all for listening to this talk. You're most welcome to give your feedback, and thank you again.